Hi, welcome everyone. I am Dr. Shirinuvasan, Associate Professor working in SLIMS and affiliated to Bihar University. So now I'm going to take classes on basic chest X-ray interpretation. So I'm doctor in radiology department working for more than 8 years. So now I'm going to talk about how to read the chest X-ray. So chest X-ray is the basic fundamental thing. So every doctor should know about how to read the chest X-ray. So now we are going to see what is X-ray and what is chest X-ray, what are all the different views, and how we have to interpret the chest X-ray abnormal and normal findings. First, introduction to X-rays. X-rays were discovered by Wilhelm Conrad Röntgen accidentally when he was a physicist, German physicist, working on an unknown rays. So he found that some unknown rays passing through his wife Bethesda hand and producing image in the X-ray plate. So that unknown rays, he called it as X-rays. So let us see what are the basics about X-rays. Like what is the X-ray belongs to? What type of rays these are? In which electromagnetic spectrum it is coming? What are its properties? Like that we see in the introduction to X-rays. Then we have to see about the radiographic views. So we are taking different views for different patients. So in X-ray, chest X-ray, for chest pathology, what are all the different views we are seeing? That we will see. Then how to read the film. Systematically, we will see the approach. So how to read the film from top to bottom so that we cannot miss any pathology. How to go for the normal things, normal variants, abnormal findings, and how to interpret so that how it helps for the management. So that we are going to see in the systematic approach. So next we are going to see the radiographic anatomy. So radiographic anatomy, we are going to see that what compartment lungs is there and what is mediastinal compartment. So we are going to detailedly see this. Then common lung conditions. So what are all the conditions, common lung conditions that we encounter in day to day, in daycare, in OP and ICU X-rays, emergency, everything. So we'll discuss common lung conditions next. So basically, first is what are X-rays? So X-rays are part of the electromagnetic spectrum. So like other spectrum, no light, common visible light, gamma rays, and cosmic radiation. This is also a part of the electromagnetic spectrum. So unlike visible light, which we can see directly by our eyes, X-rays we cannot see directly by the eyes because X-rays cannot be visualized, but it can pass through our body and it can produce image at the specialized plate called imaging plate, that is X-ray plate, and that can be seen as X-rays, and we can interpret what type of pathologies we have. So whenever you shine a beam of X-ray at a person, and when you put the film on the other side, these X-rays pass through the person and produces a negative image on the film. On the film, we develop by conventional method or CR method or DR method, whatever it is, we will see the film so that we can identify easily the pathology, whatever inside the human being. So how it produces image? So as humans, we have different types of tissues. We have skin, subcutaneous soft tissue, intermediate muscle tissue, then intermediate dense other structures, nerves, vascular structures. Then we have strong bone structures. So we have different density structures. These different density structures absorb different types of shows difference in X-ray absorption. So bones will show high absorption. So when you see in the film, it will be appearing white. The tissues intermediate, for example, muscle, it will appear intermediate, absorb the intermediate X-rays. So it will be appearing gray. So air cannot absorb. So it will totally penetrated through the air-filled structures. For example, lungs. So it will appear black. So air-filled structures, intermediate density tissue like muscle, and strong structures like bone. So everything will show different types of absorption. So based on this different types of absorption, we are going to see the normal and abnormal pathologies. So this is the basic, based on the absorption or attenuation difference in absorption of X-rays, we are able to differentiate the tissue structures in the human body. That's how it helps in identifying the pathology. Then we will go to the views. What are all the common views we are going to take in the X-ray? So we call PA view AP view. PA means posterior anterior and AP means antero posterior. So you know what is posterior. So the front side of the body is called anterior and the back side of the body is called as posterior. So based upon the source of the X-ray, that means the tube which is producing the X-ray, from which direction the X-rays are passing through the human body, and it is reflected in the plate. Based on the direction from the source to the source to the film, and in what direction patient is exposing herself from the X-ray. So we are coining like we are telling two views. So when X-rays are passing through the posterior and go to the anterior and getting entered into the film, then we call it as PA view. And when the X-rays are getting exposed to the patient from anterior aspect to posterior aspect to the then to the film, then it is called AP view. So where will you use PA view? This PA view is more accurate because we take the gap. No, this is called film to focal source to film distance, and this we keep 6 feet. For example, we will keep 6 feet from the X-ray source. We will ask the patient to stand 6 feet apart. So why we have chosen 6 feet? That means 180 centimeter, so that we can avoid the unnecessary magnification of the cardiac shadow. So we can assess whether the cardiac shadow is enlarged in size or not. So this 180 centimeter or 6 feet is standardly we are following in PA view. So this PA view, like for whatever pathologies we want to identify in a diseased person, we can use this PA view. This PA view positioning can be done as the patients to stand erect, and they can abduct the arms towards the film, and they have to lift the chin above. So this view is called posteranterior view, which is commonly used for pre-anesthetic opinion and normal routine medicine OPs and all. We follow this PA view only to find out the common pathologies. This AP view is specialized view where it is used for debilitated patients, where the patients not able to stand and not able to do the routine life. For example, trauma patients, ICU patients, all these patients we use AP view. For example, pediatric age group, we use AP view. We will put them in supine position. There is no other way. X-rays has to pass from anterior to posterior view only. So in this, we cannot avoid the exaggeration of the cardiac shadow. So we cannot assess the enlargement of the cardiac shadow in AP view. So this is the difference in the position. This is the PA view and this is the AP view. So how the film will be obtained? So this is the AP view X-ray and this is the PA view X-ray taken in the ICU patient. You can see this is a post-sternotomy film, post-CABG patient, open heart surgery patient. They have done open sternotomy procedure and suture. These are all sternotomy sutures, and the patient is in ICU. So you can see the ECG leads connected to that. So what is the difference? By seeing the film, how will you able to differentiate the PA view and AP view? So you see this cardiac shadow. The cardiac shadow is, this is also post-anatomy film, but taken after patient discharged from the debilitated condition. So you can see the sternotomy switches here. You can see the CT ratio. I'll later discuss what do you mean by CT ratio. And you can see the normal size of the heart here, and you can see the normal lungs, which is appearing black, and in between you can see the bones absorbing white. So this is the difference between the attenuation differentiation of lungs and bone and heart. And you can see the scapula, because of the position, no, moving away from the chest wall. But here you can see the scapula is towards the chest wall or included in the chest wall, and you can see the exaggerated, and that is because of we are taking close to the this thing in mobile X-rays, we see exaggerated magnification of the heart. So we cannot assess the heart size in this. You can see the lungs appearing normal, the ribs appearing normal, and you can, by seeing the film itself, you can differentiate that the main thing is scapula, which is away from the chest wall. Here, the scapular inner margins are seen within the chest wall and within the lung margins. So this is how you can differentiate PA view from the AP view. Then you can see the clavicle. Clavicle will be obliquely placed here, and you can see the clavicle more horizontally placed. So what are all the other special views? The other special views are Decompitous view. So the decubitus view is useful. Decubitus means it may be either lying down position, it may be either lateral decubitus, right lateral decubitus, or left lateral decubitus. It is very useful in taking a lung effusion. Minimal effusion we can differentiate by doing decubitus view. So we can differentiate effusion from the consolidation also, because in PA view both consolidation and effusion will appear white only. So to opaque only. So when to differentiate effusion from consolidation, when you are doing decubitus view, the consolidation will be present in the same position, but in case of effusion, it will go to the dependent area and form the lateral. In lateral view, it will go to the dependent area. So sometimes loculated effusions you can see in the same place. What do you mean by lordotic view? Lordotic view is mainly used to visualize the apex of the lung, to pick up any abnormalities which will affect the apex of the lung. For example, any apical malignancy like Pancoast tumor or apical collapse, that we can pick up by lordotic view. And then what do you mean by explanatory view? Explanatory view is helpful for the diagnosis of pneumothorax, especially. So the air will be like lungs is getting collapsed, and you can see the air. What do you mean by pneumothorax? Pneumothorax is nothing but the air collected within the pleural space. That means the air in the between the visceral and parietal pleura. So that is called pneumothorax. So these pneumothorax you can see pick up very well in the explanatory views. And foreign body trap also we can pick up easily in the explanatory view. How to approach, how to interpret. So first, to see the read the chest X-ray film, we have to follow the protocol. So how to follow that protocol? So you should know systematic approach of reading the X-ray film. So we will see one by one how to read the chest X-ray film. So the first one is when the patient is referred for chest X-ray. So first you see the requisition form. See whether the name, age, date, sex, everything, the clinical information is given is correct. Then you enter that with the letter markings, or you can enter nowadays in the CR digital film itself, and see the technical aspects. So as the patient to be in proper position, as the patient while taking exposing to take adequate inspiration, do the centering properly, and keep the side markers correctly, and keep the KV and MA so that the exposure and adequate penetration will be given to the patient. And then after the film has come, you just see step by step, go from center to periphery or periphery to center. So let us go from center to periphery. First to check the trachea, how the position is there, whether the trachea is in central position or deviated to right side or left side. Then check the heart and mediastinum. So how the heart looks, whether the heart is in the center position or heart is also pushed towards to the right side or left side, then think about the diaphragms. Diaphragms is the margin which is differentiating thorax from the abdomen. Look for the diaphragm, whether it is elevated or whether it is pushed down. So all these things you have to check. Then see the pleural spaces, see the fissures, see the costophrenic and cardiophrenic angle, see the lungs. So generally compare both side of the lungs, upper zone, mid zone, you compare with the mid zone, lower zone, compare with the lower zone. How the lucency, any opacity seen, any abnormal vascular markings, all these things you have to check. Look for the hidden areas. So always find out the hidden areas, like hidden areas are the areas we easily miss always. Okay. So you check the hidden areas, check for the apices, check for the mediastinum and retromediastinal area. Look at the hyla and any retrohylar abnormalities are there. Check all the bones. Sometimes you miss bony pathology in the hidden areas. Then check the hyla, see the density of the hyla, see the position of the hyla. Left hilum is always slightly higher than the right hilum. Check the position of the hyla. Sometimes in collapse, the hilum will be pulled above. So that also you check. Check below the diaphragms, the gas shadows, the normal fundic gas bubble is seen or not. Check for any abnormal calcifications present in the wall or ribs. Look at the soft tissues. So if they have done any mastectomy surgery, there will be abnormal translucency will be there. Look at that and check that whether they have done any surgery, any abnormal gas densities are there. Look the bones carefully. Sometimes you will miss any destructive lesions. So these destructive lesions will give you a clue whether the patient is having any associated malignancy or not. So this is the systematic view. So first see the requisition form, then do the technical, see whether the technical details are correct. Then come for the radiographic anatomy, see whether all the normal anatomical structures are present. Then go to the hidden areas, then check the hyla, then look at the normal soft tissues and abnormal bones. So film quality. So how to assess the film quality? So you know, most of the normal patients we take PA view, and for debilitated patients, trauma patients and pediatric patients, we take AP view. And most of the X-rays we are taking in ICU, PICU, everything is portable. So we'll give you the mnemonic, okay? RIP, not rest in peace. So RIP means rotation. So R is rotation. So assess the rotation. How to assess the rotation? Whether patient is rotated to the right or left. Based on that, the image will appear, show different, so that you will get the false pathology. So first you have to assess the rotation. Then look at the inspiration, whether adequate inspiration is there or not. Then P is for penetration. The penetration will tell you that whether they have used adequate KVP or MAS. So this RIP is a mnemonic to check the technical issues. So whether they have taken properly the X-ray. So how to check the rotation? So see the rotation. You have to see the midline here. You are seeing the trachea here and middle of the vertebra. And you are seeing the medial aspect of the clavicle on both sides. So the center and the medial aspect of both the clavicles should be equidistant. If it is more in right side, the patient is rotated towards right side. If it is more towards left side, the patient is rotated towards the left side. Then contralateral side, the distance will be more and the space will be more. So look at the thoracic spine, look at the clavicles. So you have to see the clavicles are at the same level, whether it is equidistant from the midline. So that is important, and that thereby we can identify whether it is rotated or not rotated. Then how to identify the inspiration? So inspiration is like so by counting the ribs. So while taking exposure, while exposing, taking X-rays, no. So what we used to do is we will ask the patient to take a deep inspiration. So we will ask them to take deep inspiration, and in deep inspiration, we will we'll take the X-ray and we have to see, because if you take an expiration, you can see because of inadequate expiration, apparent cardiomegaly may be there. So that you have to avoid. So we have to take the adequate like adequate inspiration is very, very important. So for that 6 anterior ribs should be there and 10 posterior ribs should be there. So then we can, by counting these ribs, then we can say this is adequate inspiration film. Then quality of the film. See, this is penetration, I told you, that is rotation, inspiration, penetration. How will you assess the penetration? So to assess the penetration, you have to see the film. By seeing the film, you can just see the vertebral margins. Through the cardiac shadow, you can just see the vertebral margins. If it is like this means, then if you are able to see like this, then it is adequately taken exposure. So this is good penetrated view. So like this, you can assess the rotation. Patient position is correct. Patient has taken adequate inspiration. But then whether the technician has used proper KVP and MAS techniques. So these things you can assess in the by seeing all these parameters. Then we will go to the thorax. So what is thorax? That means radiographic anatomy. So far we have seen the what do you mean by the X-ray? Then we have seen what are the different views of chest X-ray. Then we have seen how to assess the technical factors, whether they have taken properly the chest X-ray, that is rotation, inspiration, and penetration, RIP. So then we are coming to the anatomy. So what is chest? What chest contains? So chest is the anatomical term for chest is thorax. So the thorax is divided into 2 lateral compartments and the central compartment. The 2 lateral compartments each containing lung and associated pleura. And it has central compartment which is made up of mediastinum which contains the other thoracic structures. So the thorax is having 2 lateral compartment and 1 central compartment. The 2 lateral compartments are filled by lung and associated pleura. The central compartment has all important vascular structures, that is cardiac and major vessels. Okay. What the lung route, that means the hyla has. The hyla has the connection between the mediastinum and the lung. So it has main bronchus, pulmonary artery, pulmonary vein, bronchial arteries, and lymph nodes. So this is a radiographic anatomy. This is a normal chest X-ray. So normal chest X-ray, what are all the things you are seeing? So what you are seeing, no, the loosened structure. The loosened structure is the trachea. So the trachea is in the midline. And you can see the carina. Carina is the space between the bifurcation of the right bronchi and left bronchi. So you can see the right bronchi here, left bronchi here, and here you can see the superior pulmonary vein and inferior pulmonary artery, which forms the, together with the bronchus and lymph nodes, forms the right hilum, and here same thing, which forms the left hilum. The central white structure is called the heart, and the other 2 air-filled structures are called the lungs. And you can see the angle between the heart and the lungs, that is the cardiophrenic angle, and this angle between the ribs and the lung margins is called costophrenic angle. So this is a normal gas-filled shadow, and you can see the normal clavicle here, scapula here. So this is about normal radiographic anatomy. This is a lateral view. Lateral view, you can see the heart occupying the central structure, and you can see the heart occupying the, that is retrosternal space, which is air-filled space. Then this is called retrocardiac space, and you can see the spine margins here, and you can see the hilum here. So this is a normal radiographic anatomy of the lateral view. So the lateral view, centrally you can see the heart, and you can see the retrosternal. This is the sternum, no? So this is retrosternal free lung space and retrosternal free cardiac space. See, these spaces are very important. Suppose if there is thyromegaly, if there is retrosternal extension of thyroid, this space will get obliterated. You cannot see this space. Any anterior mediastinal mass. So if you see, then this space will get obliterated. Same thing, any retrocardiac consolidation, this is a hidden area, so it will appear opaque here. And when it obscures the spine, that is called spine sign. So how to check the heart? So I told we can assess the heart size, everything in the PA view only. So first check the size of the heart, see the shape of the heart. Silhouette. Silhouette means it is a misnomer. It means there should not be any loss of silhouette, loss of normal shape. The margin should be sharp. It should not be obscured. And the diameter. So how to assess everything? So we are going to see in the next few slides. So that we call it as cardiothoracic ratio. What is cardiothoracic ratio? So by means of cardiothoracic ratio only, we are assessing the heart size. So first see the cardiac, measure the maximum internal cardiac diameter, then maximum internal thoracic diameter. The ratio between the heart and the thorax, it should not be more than 50%. Then the heart is not enlarged. If it is more than 50%, then it is called cardiomegaly. In case of children, we can accept up to 60% because cardiothymic structures will appear little prominent in case of children. Then what do you mean by mediastinum? So the mediastinum is nothing but the central part, the middle part of the heart, the middle part of the thorax. Okay. So the middle structure of the thoracic cavity, which is presenting in between the pleural sacs, is called mediastinum. So the mediastinum has superior thoracic aperture and it ends up to the diaphragm. Anteriorly from the sternum and posteriorly up to the thoracic vertebra. So if you see this diagram, so when you draw an imaginary line between the sternal angle and inferior margin of the fourth vertebra, you can divide the mediastinum, that means the space between the pleural space, into superior mediastinum and inferior mediastinum. Inferior mediastinum, further based on the mediastinal structure, that means a heart structure, whichever is anterior to the heart, that is called anterior mediastinum, whichever contains heart, that is called middle mediastinum, whichever posterior to the heart, that is called posterior mediastinum. So mediastinum is divided into by the imaginary line drawn from the inferior margin of the vertebra to the sternal angle, superiorly into superior mediastinum, then inferior mediastinum. Inferior mediastinum further divided into anterior, middle, and posterior. So you can clearly understand how the middle mediastinum, that means how the mediastinum is divided into superior, inferior further into anterior, middle, and posterior mediastinum. So what are the mediastinal structures? Okay. See, this is a heart. So if you see generally, this is a heart. So this is where the arch of aorta starts. Okay, this is the arch of aorta and it takes a bend here. That we call it as aortic knuckle. Okay. And here, where the arch of aorta starts, just close to that, you can see the superior vena cava structure entering into the right atrium. And you can see the right hila, left hila, then right heart margin and left heart margin. Then you can see the inferior border of the heart here, which is placed over the central tendon of the diaphragm. So what do you mean by silhouette sign? Silhouette, actually I told you before, silhouette is nothing but a misnomer. It is actually means loss of silhouette. So whenever there is loss of normal contour, then only we call it as a silhouette sign. So what is the importance of silhouette sign? So silhouette sign helps in differentiating. That means whenever there is a loss of normal contour based on the location, it helps to localize the disease pathology from nearby which structure it comes. So like that, so whatever the structure is silhouetted here, that means there is a pathology in the adjacent structure. Suppose if the left heart border, that means the normal contour of the left heart border when it is lost, then it is called, then it is maybe due to the pathology in the lingula. When the right heart border is lost, then it may be pathology in the right middle lobe. So like that, based on the silhouette margins, wherever it is obscured, there will be a pathology in the adjacent lobes. See, can you tell me here, what is this one structure? What is the two structure? What is the three structure and four structure? Yeah, one structure is the right out border, which is silhouetted by the adjacent lung pathology. Two is the right hemidiaphragm, which is silhouetted by the lower zone pathology. Three is the right paratracheal stripe, which is obscured by adjacent right upper lobe pathology. Four is the peripheral pleural margin, which is obscured by the pleural mass. So you can identify easily. So whichever margin is getting obscured, then there is adjacent pathology. So left heart border obscured by lingular disease, hemidiaphragm obscured by lower lobe lung disease, paratracheal stripe again upper lobe disease, chest wall by pleural or lip disease. Same thing here. So 5, 6, 7, 8. Can you name these structures? Yes. So these structures, 5, aortic knuckle, which is obscured by the adjacent anterior mediastinal structures, paraspinal line, which is obscured by posterior thorax disease, right out border again obscured by middle lobe disease, and the horizontal fissure again obscured by anterior segment of right upper lobe collapse. Okay, what is review areas? Okay, so the review areas are, that is hidden areas. So hidden areas are apices, that is whether any apical pneumothorax is there. So these are all the areas we least concentrate. So we miss any pathologies in these areas. So these hidden areas we are given by the mnemonic A, B, C, D, E. Okay. So one by one we will see what is A, B, C, D, E structure. Okay. So A is apices. So any minimal pneumothorax in the apices region we will miss. So always see the apices. We should not miss any minimal pneumothorax. And look, sometimes it may be have abnormal pathologies, even pancreatimal. See here you can see the first rib, but here the first rib is eroded. Okay, so it is not seen. So always see the bones. Then see the retrocardiac structure. The retrocardiac structure here, it is dense, and here it is any retrocardiac pathology may be present. Okay, and see the lung bases. Okay, the lung bases, you can see the air under the diaphragm, and this is a normal gastric bubble, and what you are seeing here is the air under the diaphragm. So you should not leave the hidden spaces. Then finally we will see what are all the pathologies. So we will divide the pathologies into opacity, that means the pathologies which are causing white areas, that means opaque areas. The pathologies which results in lucent areas, that means making the lung more dark. So making the lung more opaque, making the lung more dark. So those opacities which causes, that means opacification of hemithorax, making white areas are called making white areas. So these are all the common pathologies they present. Okay. So commonly pleural effusion, consolidation, collapse, any massive tumor, fibrothorax, pneumonectomy, lung agenesis, everything will be seen as opaque pathology. Okay, first we'll let us see the few common pathology. So what do you mean by pleural effusion? Pleural effusion is nothing but excess of fluid that accumulated, maybe transudate or exudate, getting accumulated in between the two pleural layers. So based on the type of fluid accumulation, it is called hydrothorax, hemothorax, chylothorax, or pyothorax. So if it is fluid, then it is hydrothorax. If it is blood, then it is hemothorax. If it is chyle, then it is chylothorax. If it is a exudate pus, then it is pyothorax or empyema. So how the pleural effusion picture will be there. So whenever you see pleural effusion here, that is be obscured. See this white area. So this white area is a homogeneous opacity which is obscuring the hemidiaphragm, left heart margin, and you can see the meniscus sign, like you can see some fluid level here. So this is very classical appearance of pleural effusion. So you can see this pleural effusion with meniscus sign. You can see the mediastinum is pushed because the fluid is getting accumulated between the two pleural spaces and it is pushing the lung, mediastinum, heart, everything to the contralateral side. So see the trachea which is pushed to the contralateral side. So this is how whenever there is a large pleural effusion, it presents with the X-ray. So this is a CT film. This is a massive right pleural effusion. You can see the collapse of lung, pushing of the mediastinum to the contralateral side. So there are so many conditions which can cause transudative pleural effusion. For example, any failure, hypoproteinemia, nephrotic syndrome, exodenoma, everything. These all conditions can produce transudative type of pleural effusion. And these are all the conditions which can produce exudative. That means either infective or based on that malignancy originated. Then we will go to the next condition, common condition which will produce opacity of the lung, called pneumonia. So what is pneumonia? Pneumonia is nothing but infection of the air-filled space, that is alveoli. So whenever air spaces are getting affected, the above one is pleural space. This is air-filled alveoli. So whenever air-filled alveoli is filled with inflammatory exudate, then we call it as pneumonia. So pneumonia appear like a patchy opacity. So it don't produce any mass effect, pushing the mediastinal structures to contralateral side. So it will be present like the patchy opacities, ill-defined patchy opacities in different areas of lung. Then collapse. So what do you mean by collapse? Whenever there is a deflated, the air in the alveoli getting deflated because either it may be due to extraneous cause or intraneous cause, then it is called a collapse or atelectasis. So whenever there is lung is shrunken, volume is lost. So this is a condition where volume loss will be there and that will pull the trachea towards the same side and this also will produce the opacity. So you can see the volume loss, see the fissure is pulled and see the trachea is pulled towards the collapse side. What are the causes of hypertransladiency? So far we have seen the conditions which produces opacity. So now we are going to see what are all the conditions that is producing hypertransladiency. So hypertransladiency can be produced by pneumothorax and by removing the soft tissue structures or absent soft tissue structures like absent pectoralis muscle in Poland syndrome. Then lungs, the common condition is air-filled abnormalities like COPDs, especially empyema. All these conditions can produce hypertransladiency. So first common condition we will see, that is pneumothorax. Pneumothorax is nothing but abnormal collection of air between the pleural spaces. So that patient cannot breathe. They will suffocate. So pneumothorax, the different types are there. It may be primary, secondary, or tension pneumothorax. So this is a film, tension pneumothorax, where you can see the air-filled dark structure here with the pleural space, compressing the lung, causing collapse of the lung, and trachea is pushed to the contralateral side. And you can see the hemidiaphragm is pushed to the downwards, to the. So this is called tension pneumothorax. So this is a CT film. You can see the air-filled structures between the pleural spaces and resulting in collapse of the lung. The next one is COPD. COPD, the common condition, that is terminal destruction of the alveolar spaces, which result in excessive accumulation of air within the air spaces. So this is called emphysema. So emphysema, again you can see the poorly, the sparsity of the vessels, and hyperinflated lung fields. You can see the flattening of the lung margins and the barrel-shaped chest, and you can see the exaggerated air-filled retrosternal and retrocardiac space. So this is emphysema. The common complication of emphysema goes for pneumothorax. See, this is emphysema gone for pneumothorax. You can see the apical pneumothorax here, right sided. The half of the hemithorax is occupied by the air. Then the other common emergency condition is pulmonary edema. So pulmonary edema is nothing but fluid accumulation due to because of failure or overload. It may be cardiogenic or non-cardiogenic edema. So you can see the pleural lines, the fluid-filled lines, that is called the Kerley B lines, minimal pleural effusion, fluid in the fissure, and peribronchial cuffing. So you can see these small white subpleural lines. These are called the Kerley B lines, Kerley basal lines. Then we can also have causes for non-cardiogenic pulmonary edema. So non-cardiogenic pulmonary edema may be gravity dependent, and it appears with the prominent air bronchograms, and perihilar bat wing pattern you can see classical. So you can see this is a perihilar bat wing pattern. So this is both of this. No, you can see perihilar classical bat wing pattern. So this is called pulmonary edema. That is the typical spotter. So whenever you see perihilar bat wing appearance, think of pulmonary edema. So that is the emergency. That's why we kept this also. So finally, let us discuss about one clinical question. So can anyone describe what are all the findings in this X-ray? Yeah. So see, the trachea is there, both clavicles are present, and what you are able to see here, that is slightly elevated left hemidiaphragm. So left hemidiaphragm is elevated, and here something is there. Okay, there is drooping of the shoulder, and you have seen the space between the rib and the scapula is increased. So what is the abnormality? So the history is recent increase in shortness of breath. There is no fever. Is having left shoulder and pain. History of chronic smoking and weight loss is there. Yes. What is the pathology? If you observe here, there is rib destruction, and you can see apical shadowing, increase in extrathoracic soft tissue density. See the density. This space is more. Sorry. This space is more. This is extrathoracic space. And see this scapula and see this hemidiaphragm. So hemidiaphragm is elevated. So there is some pathology in the apical part of the lung. Rib is destroyed, and extra-axillary space is more, and you can see the elevated left hemidiaphragm. Can you guess what is this? Yeah, this is the malignancy. So this is Pankos tumor with the destruction of rib and resulting in phrenic palsy, which results in elevation of the hemidiaphragm. So what are the findings? So from history wise, he is a smoker with weight loss, and you are seeing left apical subtle mass. So that mass resulting in what happened? So it results in destruction of the rib. So that mass results in phrenic nerve palsy, and because of that, the patient is having raised left hemidiaphragm, so resulting in phrenic nerve palsy. And the raised extrathoracic space is mainly due to paraneoplastic syndrome, that is brachial plexus infiltration. Because of brachial plexus infiltration, the patient is having severe arm pain and axillary soft tissue swelling. So if you see in the X-ray again, retrospectively, you can see there is you can see the air bronchogram here, drooping of the shoulder, increased extrathoracic space, destruction of first rib, see the first rib destroyed, and there is elevation of the left hemidiaphragm. That is due to phrenic nerve palsy. Okay, thank you very much. Just I will summarize whatever we have discussed in this. So this is basic interpretation of chest X-ray class, and we have seen what do you mean by X-ray, and which spectrum it belongs to, and what is chest X-ray, what are the different views of chest X-ray, and how it helps in identifying pathology. Then technical aspects, the mnemonic RIP, so how it helps in identifying whether any technical fault is there or not. Then systematic approach, and then systematic approach from central to periphery, how to see. Then what do you mean by, what is the radiographic anatomy, what is thoracic compartment, and what two lateral compartment has, and what about central compartment, what do you mean by silhouette sign. Then we have discussed the hidden areas. Then finally the common conditions which producing opacity, then common conditions which producing hypertransradiancy, then emergency conditions like pulmonary edema, then finally one clinical question to look for hidden areas and identify the abnormal findings. Okay. Thank you very much for patient listening. Thank you.